much for having me speak today. This is not a formal lecture, so I'm going to respond to your questions and go back and forth, and hopefully we'll have audience contributions. I want to preface any comments about technology by saying that from a perspective of National Institute on Minority Health and Health Disparities, we think that race and ethnicity, or race or ethnicity, and socioeconomic status are two fundamental demographic factors that influence health from A to Z. And this should always be considered, measured, and if they're not involved, then fine. But from a science perspective, they're important, and from a clinical care perspective, they're important. And fundamentally, from a communication messaging perspective, these are factors that are really important. And so, to think that we want to be unbiased and not think about, well, you're white or you're this or that. No. I mean, these things matter in what happens and how we take care of people and how we communicate. Second, our institute focuses on science. Obviously, we generate information. We're about discovery. We're also about reducing disparities, and we're about finding interventions that work. We've been dealing and observing and knowing these disparities in existence for decades, and I think nothing has brought them out so dramatically as COVID-19. I think now I would say that NIH leadership and all the institutes at NIH and most people in the Department of Health and Human Services are focused on equity. They're aware that these things we're not making progress, and whatever progress we had made over the last couple of decades have been thrown back dramatically by these disparities. There's no question about it that Latino populations in this country have had the biggest burden of COVID-19 compared to any other group. And this is not to say, oh, we're the worst, that's what the data show. Most cases, most severity in terms of hospitalizations, highest mortality. 3 years of projected of lost life expectancy. And if you look at Latin America, even though it's not discussed very much in the media in this country, in the US, there's clearly no other region in the world that has suffered as much as Latin America. And the suffering is not just deaths and hospitalizations and the consequences of that for families and individuals, but also economic loss. Whatever progress our side of the continents had been made in the last 20 years, much of it has been lost in a year and a half. We think it can be recovered, but of course, it's a long ways to go there. Now, how can technology help? Clearly, when the pandemic hit and we were told to shelter in place, that was one of the factors that led to such disparities, that many of our people, many of our community didn't have the privilege that I have of being able to do 95% of my work from my home. Whether it's through Zoom meetings or my academic work or my research or my decisions on the institute. And believe me, in the last year and a half, I probably have worked harder than I ever did since I was a resident. And I'm, it's kind of reaching a plateau because you can't sustain it forever, but it has been a huge challenge. Second is, how do we obtain and leverage good information? So when the clinics shut down in March of 2020, and they said, no, we can't see patients. I'm familiar with community clinics here in the District of Columbia. Well, they said, well, you can start doing telemedicine. What happened? Well, the Latino patients who went to the community clinic, very few of them have desktop computers. Very few of them want to use their data for a video conference. And so most of them end up being telephone consults. And guess what? Insurance companies say they won't pay telephone conferences, consults. They only pay video conferences. Now, of course, we're now back in in-person care for maybe 75, 80% of visits. But doing more telemedicine is actually a good thing from the pandemic, because I think it increases access, Many of the visits don't need a physical exam. It saves time for both clinicians and patients. And so the digital divide became quite stark. It's not just, can I use this desktop? Can I use my digital, I'm a digital immigrant, so young people know how to do all this secondhand. And then can I read? They don't have the hardware, and they don't have the resources to pay, a monthly fee for internet, or to have an unlimited data plan on their phone. Most of them are using the phone, and it's limited data, and they can't just be using their data plan for doing all the stuff that many of us. So I think we have to find societal solutions to this. More broadband, more accessible, less expensive, or in many cases free, sort of like we do with electricity, where there's subsidized power for low-income families. Well, we should have subsidized internet. And then the last point I'll make, which is a really, what do we do with all this misinformation? Our community has not been shielded from that. People start tweeting or sending, or Facebook, or on any platform, including just looking at websites, with really myths or overt lies about the pandemic, about the vaccines, about any kind of information, related to this. And we read about, well, it's some of it is partisan, it's politics, but this goes well beyond that. This is disseminated throughout our community, or even sort of going to say that, oh, they're using aborted fetuses to make the vaccine. I mean, there's a lot of misinformation out there, mistrust being supported or promoted through this. And I think public health science, clinicians, we need to be much more proactive about good information and addressing these misconceptions. So Ilan, turn it over to Ilan.
Very happy to hear that you are already working on that and working on solutions to try to overcome these digital barriers. Ilan, love to hear your thoughts.
First of all, thank you so much, Dr. Pérez-Stable. It's always a blessing to hear you, and I echo your sentiment. In the beginning of 2020, we had, and I work in a federal qualified health center, and we had a beautiful plan to develop telehealth for the community, that it will be done in like 2 to 3 years. And we were creating all the pathways and the protocols and absolutely everything from all the corners of the company. And suddenly we needed to switch gears. And we started hearing about COVID-19, making sure that we needed actually to shelter in place, making sure that we were actually helping and doing that stuff. Then from a fair qualified health center that was doing probably 99% of absolutely everything in person, we switched to 99% of absolutely everything that we were doing via telehealth. Then it was a complete shock for everyone, because we knew that the system would work. We were preparing absolutely everything, and we were very geared to it. But there were a couple of issues, like us as the medical providers. Yes, we want to use it, but we need training. It's not like that. You turn it on and it works. And the other side, the other way around, your nurses, your team, your mental health providers, your dental offices, everyone needs to switch the mentality for it. Then I did, and I'm going to concentrate on the things that I felt we are doing right now that we need to continue repeating. Before, it was a luxury for our communities of color to get telehealth services. It was simply not there, because we were hearing about this right now. It was not even on the books to get paid by Medi-Cal, here in California, or Medicare, and it was just not there. And suddenly we actually have access to our patients. And part of COVID-19 equity issues that we had was that we knew that, when our community was asked to stay at home and shelter at home, it worked for maybe 2 or 3 days. But if our community doesn't go out there as essential workers, there's no food for that day. It's not paycheck to paycheck, it's day by day. Then, right now, having all these opportunities with telehealth, informational stuff, and not just for medical stuff, but mental health opportunities, certain preventive dental activation for the community, group visits against diabetes, mental health, that it's such an important topic that we're having, community health specialists actually, and workers, promotoras, going out there and helping our community, and all those stuff would never have happened if we didn't have the opportunity and the need right now to get COVID-19, education, treatment, and most importantly, yes, we have the pandemic going around, but COVID-19 didn't call hypertension and diabetes go like, oh, by the way, I'm coming in town, please live for a couple of months or maybe a year, and suddenly all the stuff that we're doing for COVID-19, the testing, everything else, we suddenly reminded ourselves that, we need to check insulins, we need to check sugars, we need to make sure that the high blood pressure are doing all that stuff. And I think that part of the gaps that we had, apart from the technology part, was actually the using our medical devices in our community as a tool for health. We were streaming, we were using it actually to do, like our important things of life, but we never use it as a tool for health. Then right now with COVID-19, it actually opened an amazing framework where our communities can jump years forward with all these things, having that basis of, yes, we need, broadband. Yes, we need, effective cell phones that work, that they're not just flip phones. Or if we're doing texting, let's make sure that our systems are talking to each other and they can make a difference. And all of these things, I think that will move forward and it will be amazing for all of us, and especially to our community, because something that we saw as a luxury right now, it's a right. And most importantly, it's actually helping all our community, especially here in California, that I'm doing telehealth a couple of times a week. Going inside, and this is actually my final 2 minutes. In Mexico, I used to go to the houses of my patients. It was kind of that feeling. And with my pediatrician used to come to my house. This is the first time in my life here in the US that I'm actually inside of my patient's house. When and I can see the dynamics with la abuelita and abuelito, the grandparents and the kids, and see different things that I do not see. And I start to feel again part of that feeling of community health, most important, being part of the familia. Then thank you so much, Dr. Tony Lloveras, and back to you.
Thank you, Ilan, for also bringing a focus to some of the more important ways that technology can reduce these disparities. And we all appreciate your videos that I feel were timely and just explained the COVID-19 vaccine in a way that was approachable, that was accessible, that was well understood in both Spanish and English. And that, that's the type of messaging that is important and utilizes technology, because social media now is something where you need to use technology in order to access it. And we know that in a Latino population, the majority of people access the internet through their mobile device. And so they're naturally exposed more to things on social media. And so I'm glad that you're there representing some of the important issues that need to be brought up. And I'll just bring up briefly, just because it's on the topic, but we haven't made an official announcement, but Latino Coalition Against COVID-19, along with one of the coalition partners, was recently awarded one of the HRSA grants for promoting vaccine in vulnerable communities. It's called the Local Community-Based Workforce to increase COVID-19 vaccine outreach. And one part that we're playing a role is through the Digital Compañero program. This was an idea that we had thought up a while back, but now with funding, we can actually turn it into a reality and address some of the issues that Dr. Pérez-Stable was referring to earlier, where there's no internet access. So promotores are going to go into the community, provide hotspots, and then we're going to be providing remote teaching so that they're able to gain the digital literacy so that the digital exclusion can stop and they can be digitally included in some of the more important ways that they can collect health information so that they have reliable health information, not just what's on social media. And so I thought I would just share that with you all, since I think it's a project that will benefit our communities and help build some of the health equity that we want to. But we want to hear more from our speakers, because there are many questions that we have that are related to this issue. And so, given the digital divide, and the lack of high-speed internet access, along with low levels of digital literacy, how could we promote development of technologies that are inclusive, that are incorporating the voice of the community, so that we know that it will produce a product that our communities will use, and one that will serve our marginalized Latino and Black communities.
Well, if I may jump in, I think much of what you're referring to, Daniel, really is beyond the scope of either, I would venture to say, Ilan or myself. It's more a government or private sector commitment to do this. And as I alluded to earlier, we need to look at access to internet as we do utilities. It's another utility, and the same way, of course, everyone thinks of it as TV, it's entertainment, but the internet becomes essential for information communication and keeping people connected. And so it should be a societal priority to make it accessible to everyone. And maybe we can address some of it in some demonstration projects or research, like you suggested. Well, having community health workers go into the home and provide a hotspot, but that can only last while the person's in the home. Or we use libraries as an example. Public libraries, at least while I was in San Francisco, were usually full of people using the internet. And so I think that's another option. But of course, they closed during the shelter-in-place order. So we have to think out of the box. How do we address these barriers so that our communities are really empowered to be able to make their own decisions, communicate adequately, and balance the information? And this doesn't become another privilege that really increases inequality as opposed to decrease. I mean, information can be a very liberating and powerful force, but it can also be very disruptive and create, a false reality, as we have seen. So we really need to be proactive about doing this without becoming, repressive or, censors, about what is. And we have to really, join the, okay, we got to get the right information, get videos out there explaining things. And of course, in Latino communities, for those who prefer to speak Spanish or monolingual, it needs to be in Spanish and English. So I think that this is beyond the power of the health force, but we can be a voice at that table to advocate for this as part of health.
And I completely agree, and it is a difficult question to answer, because I agree with you that a lot of this is up to government to create the way it's distributed and the prices. And I did want to bring attention to a program that was recently started for those who have family members or anyone who's watching who's having difficult affording internet. There's an emergency broadband benefit program that the FCC recently started, and you get a discount of up to $50 per month towards broadband service. And so you just want to Google that emergency broadband benefit, and that's something that can be applied for right now and may be helpful if have neighbors or family members who have neighbors, or have, maybe you heard that they're having difficulty affording that. It's a program that can be applied for right now. Dr. Ilan, maybe you can share with us some ways that you've used technology to help advance health equity and improve healthcare for your community and for your patients. What do you think maybe some of the more important things that are available that maybe folks don't know about?
One of the things that I love the most is that, as doctors, we have the honor to see the patient 50 minutes, 25 minutes, half an hour. But the real magic happens when they close the door of the office and they go outside to the community. That's where the tools, apps, and technology actually comes at hand. And a lot of the issues that we're having right now, especially with knowing that, if you have chronic conditions like obesity, high blood pressure, diabetes, and all that stuff that we have seen in our community, you have a higher probability of having issues with COVID-19. Then one of the things that I'm enjoying a lot is there's a lot of technology out there. There's already available in Spanish, and actually I call it Spanglish because some of them actually are Spanish, English, and other parts of the world. But there's apps that I help them download, and they can start tracking things that we never tracked or never talked about. Let's talk about your BMI, and they can actually see what's happening. And the other thing is that in the old days, I needed to bring my patients to do, weight checks and let's see how your diabetes is going. And right now, with the opportunity of having all these things virtual, we can actually, have a weight scale to report directly to me and have that conversation when we're talking about equity. That way, they don't need to lose a day of work. They can still see, like our comprehensive rounds, meaning, they will see the nutritionist, they will see, if they need a promotora, mental health, and the doctor, and also, a diabetes prevention program, the class of, how can, when other people, a group visit, then all of these things would never happen in our communities if it wasn't for the technology that we have. And I agree, Daniel, with a lot of our patients, we just call them and we do the group visit by phone, and I love it because we were not used to it. We had tools there that we were not used to it, and there's certain groups that we have seen that they are actually loving having Zoom meetings with a promotora. And actually, we did a lot of work with diabetes or our diabetes group visits, and answering COVID-19 questions. Do I, a lot of people were like very afraid that I have diabetes, I don't want to get the vaccine. It's like, no, wait. Please get it. It's actually designed for you. We need you to get it. And all of those conversations, if it was on my office, there's a higher possibility of not coming in because, all the barriers to get there. But by phone, they can actually take a 20-minute rest of the day in their lunch and actually have a decent conversation, take care of themselves, their families, and make a difference.
Excellent points. Excellent points. Yes. So we're going to be
perfect. Thank you, Daniel.
Thank you, Miyuki. So we're going to be opening up for the question and answer portion so that we can see what are on the minds of those who are tuning in. And we do have a little bit of a voting system so we can, if you see a good question, feel free to upvote it, and those ones will move up to the top. And so we have a question from Don Moore. Should doctors and stakeholders advocate for the infrastructure bill for broadband in low-income communities where the incidence of health disparities is high?
I can take because it's a policy question, I can probably take it as a private citizen right now. Right now, any access that we can for our patients with technology, it would be an investment for the future. We have seen already how dependent we are in times of crisis to actually use all of this infrastructure. And most importantly, we're starting to grasp the possibility to help our communities with preventive services and even taking care of their diabetes, high blood pressure, and other stuff. With, before 10 years ago, this was a dream. It was like, yeah, you can buy like the little kit that is like probably like $10,000 and we'll have like a special thing. Right now, the kits are very low cost and you can actually buy it in a lot of the supermarkets out there, and you just plug stuff and it's not the cheapest thing, but it's it's something real. Then we need to figure out how are we going to leverage all the things that are coming our way and making sure that first of all our community has the infrastructure for it to then it's a mentality shift. There will be people that they will still like to go to see the doctor. What's adequate for each case, and we will need to have that curve in our communities to get used to that part. But I'm extremely excited.
Hey, that's a very difficult question to answer, and I think is also maybe borderline outside the scope of one person or one single person, but really I think has to do with people coming together to speak their thoughts on what needs to change and what we would like to have in our low-income communities. One of the reasons behind the coalition. I did want to bring attention back to this question that was answered, but I just wanted to give Dr. Pérez-Stable a chance to share with everyone who didn't get a chance to see it in the chat. So the question is from Kenneth Dominguez, who recently retired from the CDC. What can the federal government and local health providers do to encourage insurance companies to cover telephone consults, not just video conference visits?
Well, my response was, if you want to go through your professional societies, they're equipped to put sort of get this message into staffers in Congress to support this. It's laborious and tedious and frustrating for many of us, but that's the way things work. We had a huge breakthrough with telehealth, and I think drawing the line on video versus telephone is kind of being picky as far as I'm concerned, and especially when you consider, well, that's going to exacerbate inequality for people who don't have the access as we described earlier. My own perspective on this, though, is that our healthcare system should really be moving towards more of a population-based healthcare, so that rather than each visit that you do gets compensated and then it's volume over quality. We have a group of doctors and nurses and other healthcare professionals who say, well, we're going to take care of this population, and the population be defined whatever. This is sort of the accountable care model or the staff model, HMO, where and then you have a block budget and you take care of the population. Some people don't need a whole lot, and some people need a lot. And you're not worried about, I better make sure I bill everything, because that way I can pay for the folks over here who are really going to bleed the system. And the British do this, have done it for a long time. It works. I think that the experience in the US for healthcare systems that do this show that they have similar outcomes, if not better, than most other insurers. And there is a east-west bias. I mean, in the western part of the country, it's much more common to see this, whether it be a group health, a Kaiser, a Mountain Health, or a variety of other. And in this part of the country, it's almost like people don't do it. Now, Boston is different than the Washington Mid-Atlantic or New York City, but I think that, and if we are going to improve the Affordable Care Act, this is a approach to do it. Of course, there's probably 50 problems that have greater priority right now for the administration, but eventually I think we'll get to this in improving health. So.
Thank you for sharing that, Dr. Pérez-Stable. There was a very interesting question that I just wanted to ask everyone, since I got so many votes. But one of the main reasons, this is from an anonymous attendee, one of the main reasons that I have been very hesitant to have the vaccine is because of the information regarding the long-term impact of having the type of vaccine that is currently available for COVID-19. It is scary for me to see reports about leading scientists speaking against the vaccine. Is it true about what they say, that the vaccine will damage your body's ability to fight against disease long-term? And what is your opinion about these scientists? Either one of the speakers.
Well, I mean, as an institute director at NIH, I mean, I feel obligated to really advocate against this perspective. The science behind the messenger RNA platform was in development for 20 years. So this is not something that just appeared in the last year. Like many advances in basic science, it wasn't like they started out saying this is what they started out by saying, let's study the structure of the proteins of the virus, let's take photos of it. They have better and better tools to study this, and then to be able to deliver a prescription, sort of, if you wish, for our body, for our muscle cells, all to manufacture antibodies against this new virus that is causing so much death and disability, was an amazing accomplishment. But nobody predicted it would be 94% effective at preventing clinical disease. Nobody did. And it's probably 98, 99% effective at preventing death. Long-term effects, well, it's only been a year or less than a year, or counting the clinical trial, a year. So it's hard to project, but, go back to, I'm old enough to have had measles. I saw measles in myself and my siblings. Nowadays, measles is rare in the U.S. And I would venture to say that most of the trainees I worked with at UCSF had never seen a case of measles. And that's a huge triumph. That was a live attenuated virus. It was a different model in this. But at the time, people were, what's it going to do to you? What's it going to do to you? And we see that these long-term effects of the vaccines are just not there. But, science is empirical. We need to follow people. It's 160 million people in the US have received the vaccine. And so we will have lots of information on potential, long-term effects, if any are shown. Right now, it is clearly the only effective tool that we have to blunt and hopefully bring this pandemic under control. Everything else is help on the edges, including, wearing masks help, but this is the only tool we have. And I just make a plea for everyone to get vaccinated and promote the vaccine amongst your patients and families and friends and peers. Thank you.
Thanks, Dr. Pérez. I would have to echo what he said at the end. Rarely do we all have a chance to save lives, but if you're able to convince a loved one, a neighbor, a community member to get vaccinated, you're actually contributing to saving lives. And the more people that you're able to, I wouldn't say necessarily use the word convince, but provide information so that they could come to the conclusion themselves, which is an obvious one that is, I think, obviously based on fact and information that the vaccine is beneficial. And almost every side effect that's brought up as a potential fear or barrier to getting vaccinated, that same side effect occurs in the disease itself. However, it's much, much more likely to happen from the disease. And so if you just look at a risk-benefit ratio, blood clots, for instance, 6 per million from vaccines, some studies are saying, multiply that by 100 to 1,000, and that's what happens when someone gets COVID. And so it's really what's riskier. And, some of us would say that it would be riskier not to get vaccinated because the likelihood of complications are much, much higher. But I'll get off my soapbox for the vaccine and want to ask another question that we had received prior to the starting of this webinar. And one, it has to do with research, but one is, I think, an important for a clinician to answer, and one, maybe one who is more focused on research itself. And so we know that research is stronger and more beneficial to communities it serves when it's conducted by diverse researchers and community partners who make sure that the methods are valid, culturally appropriate, linguistically appropriate, inclusive of historical and cultural context. And along those same lines, funded projects are more effective and meaningful when funding decisions include communities affected by the question being studied. And so my question for Dr. Shapiro is, what are some ways that we can encourage community members to be part of clinical trials, since we know the huge disparities that was recently, brought into the limelight by a New York Times article about a year ago, 2 years ago, maybe longer than that, showing that the numbers are so small, makes some of the studies difficult to generalize. Is this relevant to my population that I'm working with? And so you're on the front lines working with patients. What do you think are some of the ways that some maybe incorporating technology, but what are some of the ways that we can try to encourage or give confidence and help people see the value in being part of clinical trials from those who are in vulnerable, marginalized communities?
I completely agree with you, because representation is not, if you're, someone actually told me probably like 2 weeks ago, this phrase that if you're not on the table, you're the main dish. And that's something that we want to avoid completely. If we are not counted and we are not having a conversation, that's why one of the important things that I have seen, for example, with the National Hispanic Medical Association, that is pushing a lot of all of us, is to make sure that we're represented. And we have seen it, thanks God, with COVID-19 vaccines. If you compare how they designed a lot of protocols to test Moderna, Pfizer, and Johnson & Johnson, and even, AstraZeneca in other Latin countries, it's starting to resonate the importance of making sure that the medications and treatments that we're using are adequate and tested in our communities. The issues that I have, Daniel, some of the times that the conversations are like, why the hell I want to be part of a research project? Why is important for me? I see all these movies and crazy stuff about medications and the third eye and like multiple hands after getting in, and we have that feeling, and we need to figure out a way to demystify that part, and actually it works the other way around. If we participate, they can actually see if our genetics and the way that we behave and our social determinants of health and everything else that is connected can actually amplify a benefit for our community. And that's why we will not get the third eye or the extra hands. Then that's why it's the important thing that we need to be doing. And it's opening the conversation. It's making sure that they know that there's research, that they can participate. And there's tons of research. It could be from blood pressure, medication, treatments, even surgeries. There's like a huge rainbow of things, even right now with vaccines. Then that's why it's so important to start the conversation, because we are not aware on a community level that this can be it can be a benefit for us and for our community and families and everybody else, and also representation. And everything starts with a doctor, making sure that they know what can they do and start like that conversation. And I think that helps a lot.
I think that conversation piece is really important. And obviously you're in the event called The Conversation. So it makes sense that you are comfortable with that part. And hopefully we can start to have some workshops, helping folks have a linguistically, culturally sensitive conversation with their patients to increase, clinical trials, from those communities.
Daniel, it should be noted though, that the vaccine trials did okay. Both Moderna and Pfizer and Johnson & Johnson, the three vaccines that are available in the United States, had about 10% African American and about 20% plus Latino Hispanics. Now you could say, well, that's not the burden of the pandemic, and I agree with you, but they didn't. They were en route to fail, and they asked, because the government was really subsidizing all of this with big bucks. We got to that table. So Dr. Collins, Dr. Fauci, Dr. Gibbons, myself, and others met with them and pushed them on strategies that we knew worked. And they, hesitated, but especially Moderna, because they're the ones that NIH was most linked to. And then we stood up about not quite a year ago, a community engaged alliance against COVID-19 called SEAL. Really on the will and support of NIH leadership. Dr. Gary Gibbons at National Heart Lung Blood Institute and I are co-chairs. We don't know where it's going to take us, but we're now in 21 sites, including California, and I think recently in Illinois. And we are promoting inclusive participation. We're addressing mistrust, and we'll see how this community engaged model, partnering with academics and with other sectors of society, will take us on this.
Excellent points, and I did forget to address that for the vaccines, they did amazing in multiple ways, and I do believe one of them had to be reminded that their numbers were not looking good, and so then they made an extra effort, and I think that was where they reached out to you and you showed some of the important strategies that can be used that worked. And sort of the same question to you, Dr. Pérez, but a little bit different. We know that research being done by diverse researchers improve not only the sort of generalizability, but more the ability for those who are reading about the research to trust in it, to believe in it. What are some things that we can do to increase the number of Latinos and Black physicians and scholars that can enter the research field and become part of creating this research that we're using to improve the lives of Latino and Black communities?
So thank you, Daniel, for bringing that up. So in clinical care, I would say we have persuasive empirical evidence, no clinical trials, of course, you can't do that, that having more diverse clinicians decreases health inequities. And if we look at the data empirically, what do patients do? They vote with their feet. Over 50% of minority patients are cared for by underrepresented groups of physicians and nurses. And guess what? We're 14% of the total physician workforce. So 14 and 50, I mean, that's a huge load. In science, we know from empirical data that diverse research teams are more innovative, more careful, usually come up with more options. They may take more time. And this comes from the business world, from educational literature, and from science world. And promoting diversity in research teams is a high priority for NIH. So, but we have a long ways to go. Clearly, scientists who are from underrepresented populations gravitate towards, I want to do something about my community. I want to do something about disparities. And if it isn't in the community, maybe it's, working on a biological mechanism of a disease that's, disproportionately present in their community, whether it be diabetes or asthma or a particular cancer. And I think that there is an increased awareness of this. There are some legal restrictions about not being able to select people because of their gender or their race, ethnicity. But we are working hard to try to make progress. When I started in medicine, in research, in 1983, I got my first faculty job. The rate of underrepresented Latino and Black physicians, was probably 3 to 5%. So right now it's 5 to 6% are African American, 7 or 8% are Latino. That's not much progress in almost 40 years, and we just cannot continue this way. The demographics of this country has changed. 50%, over 50% of children are from minority groups, and children do tend to grow up. So we need to, the profession, the clinical care profession, the scientific profession needs to make change. And this is structural barriers that exist. And this is part of the problem. So
I'm glad that our leaders, or some of our leaders, are aware of this and are working on this. I'm just going to share my screen as a visual to the next question that I saw. This was from our audience, Amy Ackroyd. I work in a community that is 86% Hispanic. The vaccination rate is only 56% today. What strategies have you found to encourage more people to get the vaccine? And I'll just make it relevant to this topic and say, have you seen any or know of any or would like to see any interventions where we're utilizing technology to improve the messaging to help address some of these disparities? And if you can see in the image, this is from the KFF website, flipping through Black, Latino, Asian, and white, a share of the COVID-19 vaccinations, cases, deaths, and total population. And as you can see, when you click on Hispanic, the bars are much smaller than when you click on the white. So the disparities are visually obvious as well. What are some of the ways that you have seen or would like to see how we can address this issue? And this would be for either Dr. Shapiro or Dr. Pérez-Stable.
Daniel, the first thing that I think that we should do is engage our communities and understand that, by Hispanos, it's that mainly we speak Spanish, but there's like billions of different equations inside of us. And that's one of the most beautiful things that we have, is making sure that, someone in the central part of California would need different type of information that someone that it's on the outskirts of Immokalee, Florida. Then we need to figure out, how can we use and leverage, Hispano apps where you can actually engage people. And I have seen a lot of that when I go out there on the community and we do the vaccination fairs. A lot of the times, that 30-second conversation, it's the entire difference of everything. Then talking to a human being and actually interacting and going like, dog, you know what? I'm afraid of this and this and this, or you know what, when I was young, I had allergies to that. And you can actually solve it in 30 seconds, because a lot of the times they actually do not need to go to a clinic. They just have a question that it's because of fear because of being, because trying to be on the safe side, that it's not on the safe side right now, we stop care. Then, I think that if we can engage, create that type of information for our community where they can access a doctor or a nurse to answer questions at any time, right now with the app, and especially that will be kind of sharing good information and not the chismes that we have out there. I think that it could make a huge difference.
Sorry, I need to. There we go. Sorry about that. Excellent. And those are some of the ways that. And there was another question that sort of the same topic, but that was popular, was texting and WhatsApp. Do you see there's a role for that in messaging and improving vaccination numbers? And I'll just remind everyone that we are at the 5-minute mark. Thank you, Miyuki. But WhatsApp, text messaging, the data shows it works. Are we using it to its full capability? Does it need to be adapted? Is there ways to improve it?
Well, I think WhatsApp, for those of us who have friends or relatives in Latin America, is used globally for messaging and actually phone calls in a very inexpensive way. In the U.S., it's among the immigrant communities it's used, but it's not widely used. So I would absolutely promote it. It is, it's used. It can be done through Wi-Fi, which you can get in many public places. So I think that is a great tool, and there has been research that we have funded, NIH as well as NIMHD specifically, to promote, to deal with the effects of COVID-19, both mental health effects, healthcare effects, and clearly in the vaccine uptake and interventions world as well. So I'm all fully supportive of these kinds of approaches. Yeah.
And we are getting near the end, so I wanted to give the panelists a chance to have a sort of 1-minute final thoughts, little gems to share with the audience before we take our group photo and closing remarks.
Well, I would just make a plea that we all become advocates of getting our population vaccinated. It's clear that getting the 70% is not going to be enough. We need to really support this collective well-being perspective and try to deal with the individual. Oh no, I don't want to. No, I don't. And mandates are going to work because many of those people will do it if it means their job, if it means being isolated, or it means losing, having to be tested once a week. Which is, not a big deal, but it's a nuisance. Yeah, to have the swab going into your nasal cavity. So I think that's really, really important. It is the only way we can get this pandemic under control, at least that we know right now. Unless there could be other things developed. So I'll leave it with that.
Excellent.
And for my part, Daniel, and I know that we're actually on the red side. Familia, we need to start vaccinating ourselves against fear with a dose of truth. Enough is enough. Before waiting was, there was no data. Maybe it was something that people can actually justify. Right now, we are seeing the numbers of people that are, on the hospitals, and we are seeing the deaths actually accumulating. And not only that, we need to remember how we suffer as a community in the past years. And especially right now that we have something that can avoid preventable deaths and suffering. Familia, we need to act upon right now. If you have doubts, it's okay to have doubts. It's okay to have fear, but make sure that you're doing the best thing for you and your family, getting the correct information, that it's evidence-based from the millions of people that we have had the vaccine, and making sure that you understand that people right now that are vaccinated, that are well protected against a lot of the complications that people that are unvaccinated are having. And familia, continue vaccinating, continue having a conversation, and we are completely here for you.
I couldn't have said it better myself, Dr. Shapiro. Thank you, Dr. Pérez-Stable. I know your time is very valuable. Dr. Shapiro, the same to you. We really appreciate you coming out here, answering some of the questions from the audience, answering our questions, answering some of my questions, because this is a difficult time for everyone. And as we all know, it's almost become a household term that disproportionate. So Latinos have been disproportionately affected. Dr. Pérez-Stable was talking about this right at the beginning. I don't think there are anyone who's trying to argue against that fact. That is something that is shared across all news stations, whether it be right wing, left wing. And one of the things that the coalition, why we came together, was because what is being done to counteract the disproportionate effect. So how are we disproportionately or proportionally redirecting funds to Latino communities? What are we doing so that we can overcome these barriers? We've known for a year the root causes of why Latinos have been disproportionately affected, and what has been done so that as we're entering what some would call a fourth surge, the same thing doesn't happen again. And many would say that the root causes, the lack of health equity in our communities, is what is going to once again most likely have Latinos disproportionately affected by this Delta wave. And we really need to work together, have a unified voice so that we can have conversations with the policymakers that normally we feel are out of reach. But by coming together, we're able to have these kinds of conversations, change the narrative so that if there ever is another pandemic, or if there are any other future waves, they don't happen in the same way. They don't attack the vulnerable communities. And instead, we're doing things actively with interventions, research-based, evidence-based, that prevent this and protect our communities. So thank you everyone for joining in. And please, let's keep this conversation going. Please sign up. We have the feedback form here, and on the website, you can sign up to be a member or a supporter. And we have these conversations ongoing through regular meetings throughout the country. So please play your part. And thank you once again, Dr. Pérez-Stable, for joining in.
Thank you for inviting me. It was really great. And I'm glad that we got to answer some of the questions. But yes, for future time, we'll have others, I'm sure.